My article tonight was called "The Risk of Hypotension Following Co-Prescription of Macrolide Antibiotics and Calcium Channel Blockers." It was published in the CMAJ in 2011. So just similar to what Arbeau just did, I'll go through the details of the paper, and then I use the user's guide to the medical literature to do my critique. So I'll be doing that after. So why do we care about this topic to start off with? I didn't much until I actually read this article, because I didn't know. So this is a little practice changing for me, but macrolides and calcium channel blockers are both the most, in anyone's top 10 list for most prescribed medications. Macrolides specifically are the most prescribed class of antibiotics. Macrolides, and specifically clarithromycin and erythromycin, inhibit cytochrome enzyme P450 in the liver, and specifically isoenzyme 3A4, whatever that means. And drugs that are broken down by said isoenzyme accumulate in the blood. And calcium channel blockers are an example of such a medication that are broken down by this enzyme. Calcium channel blockers are common long-term chronic medications that people are often on. Lots of indications: hypertension, coronary artery disease. So especially in the patient population they looked at, it's a common medication that we're going to see, and since we prescribe macrolides so much, this is a complication of, this is an interaction we should be aware of. In terms of the methods that they used, it was a population-based study. They specifically looked at residents greater than the age of 66 in Ontario, and there's a reason for that. They got prescription info from the ODB, hospital admissions from CIHI discharge abstract database, and they used databases using our health card numbers that were linked to get demographic information. This was an Ontario done study. Specifically, they looked at all patients who were on calcium channel blockers between April 1st, 1994 to March 31st, 2009. So it was a significantly long study period, 15 years. And inclusion criteria here were patients must have been on continuous therapy, which they defined as someone who had a script refill for a calcium channel blocker at least 180 days after their initial prescription. So that's why they looked specifically at patients greater than 66 years old, because if you were 65, they wouldn't have had the data from ODB for your previous year's prescription. So that's where that came from. Patients were considered to have stopped their calcium channel blocker if more than 180 days had passed without a refill. And these patients were then followed for 60 days after stopping for complication rates. And observation of patients ended with one of their outcome criteria, which was hospital admission, admission with hypotension, death, or stopping of the prescription. Specifically, they excluded patients in their first year of eligibility under ODB for the reason I just stated, or patients who had more than one macrolide prescribed in the 30 days before hospital admission. So specifically their endpoints, they were looking for patients who were admitted to hospital for hypotension or shock. And they examined data specifically for patients who were hypotensive on initial presentation to the emergency department. Okay, so in terms of study design, it's called a case crossover design. And kind of what you need to know about that is a crossover study is basically a study where the same group of people are exposed to two different interventions at two different points of time. So some of the keys here are that the intervention needs to be short, and it can't impact your likelihood of getting the outcome of interest later on. So the effect must be short-lived. A case crossover study is just a case control version of a crossover study, so patients serve as their own case controls. And really the question that they're looking at with any case crossover study is, was this patient doing anything peculiar or out of the ordinary right before disease onset or outcome onset that could explain the outcome. So that's just kind of basics on the design. So again, the case controls were, it was nested in a population of people already on a calcium channel blocker, so that they, using this design, they really minimize a lot of the biases that we can't control for otherwise, since patients served as their own controls. They specifically measured odds ratios instead of relative risks, simply because you can't calculate relative risks from a crossover study like this one, a cross-sectional study, because you don't know the full prevalence of the disease. In this specific example, you're specifically picking out people with the outcome, and then you're working backwards to try to come up with risk factors. So odds ratios, probability of an event happening over not happening. So you have those two numbers, but you can't calculate relative risk because you don't know the prevalence of the disease. So that was the most I know about the stats about this study. All right, so in total, down to the results, they had a lot of patients. Over the 15-year period, they had over 999,000 patients who were on a single calcium channel blocker, and the median age of patients was 71 years old. Out of this 999,000 people, out of those 999,000 people, they had 7,100 people who were admitted specifically for hypotension. So that's a rate of 0.7%. So it's a very rare event. Out of the 7,100 who were admitted with hypotension, 176 had received a macrolide in the 7 days prior to admission to hospital. So again, their treatment group, if you will, or exposure group was people who had had a macrolide 7 days before admission to hospital, and they were comparing that within the same person to 7 days in the previous month. So assuming they hadn't had a macrolide in that part. So I think table 2 goes over their main results, and that presents the odd ratios for hypotension or shock on admission. And really what to get out of this is the odds ratios were pretty impressive for erythromycin and clarithromycin, which from previous case control studies and just pharmacology, we know block the specific isoenzyme. Their odds ratios were 5.8 and 3.7 for erythromycin and clarithromycin respectively, with fairly decent confidence intervals, and they did not find a statistically significant difference for azithromycin. That odds ratio was 1.5. So whatever effect they saw in this study was kind of explained by what we knew about the pharmacology of these drugs going in, that erythromycin and clarithromycin, by blocking this enzyme, should increase calcium channel blocker levels and thus potentially cause hypotension in patients. But azithromycin, which does not have that same effect on P450, was not found to increase calcium channel blocker levels and thus lead to hypotension. The findings these findings were consistent for both non-DHP and DHP calcium channel blockers, but it was stronger for the non-DHP calcium channel blockers, and that's table 2 and 3. So again, pretty impressive odds ratios. So the interpretation there from the study is that it increased patients' short-term risk of admission with a calcium channel blocker plus a macrolide antibiotic. And again, this is consistent with what we know about biology and case reports. Certain limitations of this study, just quickly before I go into the critique, they couldn't quantify medication adherence was one big thing. Another thing where physicians were obviously prescribing this macrolide antibiotic to treat some sort of infection, and they weren't powered really to look at severity of infection in this study either. So although this kind of the pharmacology makes sense, we don't know if out of these 7,100 patients, if they were admitted for hypotension because they were also septic. So that's a limiting factor. As well, apparently the accuracy of the diagnostic codes for hypotension have not been well validated. That is a bit beyond me. So I guess there may be different definitions of hypotension depending on what center you're in. And the other thing that was important is that they weren't powered to look at bradycardia or the magnitude of effect for each calcium channel blocker. So bradycardia would have been nice to look at because you would expect if the serum levels of this calcium channel blocker are going up, you would get bradycardia and hypotension, but unfortunately they weren't powered enough. And then author number 3 was a consultant for Pfizer, which I think manufactures azithromycin, so that's something to know as well. So that's kind of the basic overview of the study. Going through the critique, so again, I used the user's guide to the medical literature on observational studies. Just go through a list of questions. So with respect to the validity of the results, did the cases and controls have the same risk for being exposed in the past? Well, yeah, because they were comparing. It was a case crossover study, so each patient was their own control. So absolutely, they had the same risk for being exposed to a macrolide antibiotic. Were the patients similar for prognostic factors that are known? Again, for the same reasons, the answer there is yes. Were the circumstances and methods for detecting the outcome similar? Well, I said kind of, because we didn't really have a standard definition of hypotension. They just relied on the diagnostic codes. So leaning towards yes, but I'll stick with kind of. Was follow-up sufficiently complete? Again, yes, they followed patients until they got the outcome of interest, or at least 2 months or 60 days after they had stopped the calcium channel blocker. Were cases and controls similar with respect to the indication that would lead to the exposure? Again, each person was his or her own control, so the answer there is yes as well. And were the methods for determining exposure similar? Again, the answer is yes. They used the same ODB database. What are the results? So how strong is the association between exposure and outcome? They had a large magnitude odds ratio in both DHP and non-DHP calcium channel blockers for clarithromycin and erythromycin and not azithromycin. So again, the strength of the association was fairly strong, which supports this study. How can I specifically apply the results to my own patient care? Well, were the patients similar to patients in my own practice? Absolutely. We all practice in Ontario. We frequently see elderly patients who need a macrolide antibiotic for, say, community-acquired pneumonia, for example, and very often these patients will be on a calcium channel blocker. So yes, they were similar. Was follow-up long enough? I already talked about that. Exposure similar to what may occur in my patient? Again, yes. I think pretty much the patients we see were the patients in the study. And are the benefits of the exposure, are there benefits of the exposure that offset the risks associated with it? Well, no, because we have another antibiotic within the same class available that we can use in these specific situations, which is azithral. So personally, would I use it? Well, going into it, again, this wasn't a randomized controlled trial, but that being said, before you even started the study, the biology and the pharmacology kind of predicted this result. So that helped strengthen the results of the study. And it was their findings were consistent with previous case reports of 15 patients who had transient increases in their calcium channel blocker levels and had suffered some sort of cardiovascular toxicity because of that. So this study, their findings were consistent with what we thought should have happened. So would I personally use it? Absolutely. I mean, although the complication rates were low, we're talking about 0.7% of people had hypotension out of almost 1 million, and only 176 of those had received a macrolide as well. So we're talking about a very, very rare outcome. But that being said, when we do have a very safe alternative antibiotic within the same class, I think it's something to definitely keep in mind, and I think it has changed or will change my practice from here on in, and I'll definitely be more aware of this interaction.
I wonder if this is something that increasingly pharmacists will be picking up on.
Mm-hmm. Yes.
I get more calls from pharmacists now than I ever used to, and it's usually something like that, or I want to start them on Levaquin, and there's some other drug that they're on that I was unaware that there was an interaction.
Mm-hmm.
The pharmacist doesn't want to prescribe or dispense it.
Mm-hmm.
Forces me to change my hand.
After reading this article, I asked Sarah, and she's a pharmacist, about it, and she's like, "Oh, I hadn't heard about that." And then within like a couple of days, something came out in one of their newsletters that this was a major interaction. So it definitely will be picked up on.
Yeah, because what they don't know is how many, from the study, you don't know how many patients were on both and didn't suffer the outcome. You just know that out of patients who got the outcome, there was a higher chance that they were on a macrolide. So it's a little,
like thousands and thousands of people that were on
absolutely
both and had no problems, and then
absolutely
170 whatever that did have a bad outcome or had hypotension. So
And hypotension due to what?
yeah, exactly.
Yeah.
That was my
Right?
question about the diagnostic codes. There's like a whole bunch of them listed. Like,
But
a lot of times I'll put a diagnostic code on the bottom of the chart that I made someone, and I only put like hypotension. Like normally it's from something, so you'll put something else, and how many of those patients were missed. So maybe you're
definitely not perfect study design. No question.
Based on admission or discharge diagnosis?
Admission.
But that would be a very uncommon discharge diagnosis, hypotension.
yeah.
So it depends on how, and did they miss a ton of patients who also had hypotension, that wasn't common?
They were diagnosed with like
How did
sepsis
they-
or pneumonia.
Did they just look for hypotension?
Yes.
Or did they
Absolutely.
Yeah.
just hypotension?
Yeah.
Yep.
And,
Well,
and,
those patients
and I
are
mean, it
shocked
depends on
with
how
all
it's
the
coded,
descriptions.
right? Because what you write on the bottom of your chart and what's coded in health records might be completely different. And oftentimes we see that, right? We go back and we do retrospective studies and you pull something based on an ICD-10 code of blank, and then you're going through it going, okay, this does not fit this box at all. This should not have been coded as an ICD-10 code blank.
The other question, when I'm going through pharmacopoeia on macrolides, one of the less than 1% complications for macrolide is hypotension itself. And we're getting a 0.7% complication rate of macrolides causing hypotension.
Not 0.7% complication rate. That's not correct, because this wasn't a cohort study.
So I was so confused. Are we getting more hypotension than the drug company is quoting for the macrolide to have? Is this showing an increased risk?
We don't know that.
We don't know
We
that.
don't
So
know.
we're just looking
This is-
at what macrolides do.
Does equal causation,
Yeah.
right? So there's some sort of a correlation, there's an association, but you can't develop causation until you do an RCT. There's biological plausibility, as Samir said, certainly, but
I have a question for some of the staff here, like they have been around longer, and I just anecdotally I've found some people complain more about increased side effect profile with azithromycin compared to the other two in that class, and I'm not sure if you guys have heard that as well. I've heard more people don't tolerate azithro as well as tolerate by accident and urethro.
And also, when I was in Hamilton talking about azithromycin as well, when there was a lot of controversy within the ID population because apparently the half-life is really, really long, so there's concerns that if you're using azithro, it gets to subtherapeutic levels pretty quickly, stays there for a while, so that it can cause increased resistance. I don't know if that's actually panned out. I haven't looked at that.
Well, it doesn't have very high serum levels, right? Because most of it gets incorporated intracellularly. So there are some potential side effects of using azithromycin that we don't think about from the standpoint of therapeutics, pharmacotherapeutics. If you need high blood levels, or you need to get into tissues that macrophages and stuff don't migrate into well, then there are high tissue levels, it's not a good drug. So it depends what you want to use it for. So there are some side effects related to the choice of antibiotics. There was a large pediatric study, I can't say it's the same in the adult population, that looked at the side effects of erythromycin, and azithromycin, because the manufacturers like you to believe that clarithromycin and azithromycin are better, and the side effect rates were roughly the same. There's a little more GI upset, clearly, in the erythromycin group. It's with all the groups. Again, which formulation you use as well, because an S-late is another pharmacology. The S-late tends to have lower GI effects.
And that's what you use in kids,
Yeah,
isn't it?
yes.
Under what age?
But we don't use erythromycin anymore. Last time I prescribed erythromycin, we use a lot of clarithromycin, which has got its own problems.
I think more erythromycin is just being used as a prokinetic more so than
As a what, sorry?
it's being used more and more frequently only as a prokinetic in in ICU patients where you want to advance a feeding tube into the jejunum rather than actually for antimicrobial therapy.
But the other thing that was kind of unclear to me here is looking at the other drugs that they were on. I mean, they listed some, but there are other drugs that are metabolized with P450 that are cardiotoxic, potentially cardiotoxic. They've listed some, or they haven't by all chance listed all of them. So what we don't know is whether any of those other drugs are prescribed and whether that had an impact. Right? Because if you go back to the early literature looking at P450, and when erythromycin and clarithromycin were dispensed, they had interactions with certain subclasses of non-sedating antihistamines, and they would actually lead to prolonged QT syndrome and to subclasses. And so some of these drugs, by their cumulative effect, could have an increasing synergetic effect leading to the undesired outcome. Right, and some are there, but not all of them. That has me concerned. I mean, I don't know how much of an impact it has and whether they used it.
I have not personally seen more patients with side effects from azithro versus clarithromycin. In fact, I would say it's relatively common to see patients who are on clarithromycin who come in with vomiting and abdominal pain.
Kind of shed a couple later now that people have told me about. It's like, yeah, I was like, oh, okay. I didn't really think that myself. But.
Well, all macrolides are a little bit hard to tolerate. And I suppose the overall benefit is that the course is shorter by half. So.
So would this change your management, this paper?
I would like to say no.
Huh, okay.
Okay, well, and how many of you were at CAPE at the closing plenary, the final? Like, I think this reeks of that whole topic where something comes up, a retrospective review of the literature where they went in looking for something and they think that they found it, but nobody has proven it in a prospective trial. And then you all of a sudden everybody starts doing it, so it becomes an accepted practice without any basis, just like the bloodletting. So now,
I don't compare this to bloodletting.
because it works in the lab, we all know has not automatically translated
Absolutely.
to in the field.
I agree.
So I think that this is something that deserves our attention, but I find it a little bit troublesome that.
I think if I'm handcuffed and I can't use azithro, absolutely, I wouldn't feel unsafe prescribing erythro or chlorithro for my patient.
Why would you change your practice?
Pardon me?
Because you don't feel unsafe. Why would you change your practice with no good prospective evidence?
Because we have some evidence and there's biologic plausibility. I don't know.
Well, yes, but there's also epigenetics, and we don't talk about that very much. But this might be a subgroup, given the low incidence, or a subgroup of people who have an epigenetic predisposition to that combination of drugs, right? So,
Possibly.
if in an ideal world you could sort of drop somebody's blood on a slide and say, oh yeah, you've got those genes that are going to make you more susceptible to this versus nay, then I think you would have a thing. I think that given the low incidence in a million, the low numbers they came up with the way they did their data, and they might be higher, I don't know if I would change my practice.
I suspect we're not going to have a choice, though.
Well,
They could bring it forward.
exactly, and that's the same thing also that was brought up at that plenary session, is that then,
Gary's pointing at me. I said, blame my wife.
yeah, exactly, your wife. Well, not even blame your
No, I
wife,
know.
blame whoever it is that sends out their newsletters
Yeah.
that reads a, retrospective review of a database and makes a decision that's going to stop us from prescribing an antibiotic. And I personally, now who knows, maybe I've seen it, I didn't know I saw it because I didn't go looking for the calcium channel blocker and the clarithromycin, or nobody really uses azithromycin, so didn't look for clarithromycin on they consider that as the cause of their hypotension, but this raises a very good question that should be investigated.
Agreed. Yeah.
Well, the question is how, right? So if we're going to inform our practice from research, we have to inform our practice based on the best available information to us at the time, and we have to be ready to change our minds in the future if there's other better evidence that comes forward. But you can't do randomized controlled trials about things that harm people. You can't, you ethically can't do that. So if you want to get information about a topic on harm, typically you are looking at population studies, and this one was a reasonably well done, well thought out, well organized population-based study to look at something that is potentially harmful. So I took this paper and changed my practice. I was already almost exclusively using erythromycin because I'm kind of a believer in the compliance argument with a 5-day course versus a 10-day course. So I suppose in that sense I didn't change my practice, but I didn't use this as a reason before for prescribing azithromycin. Whereas now I will look at a patient's medication list, and if they are on a calcium channel blocker, I'll avoid the clarithromycin. I can't think of a time when I have written a script for erythromycin. It's not something I use, but I will use this article to influence my practice because I think on this topic, this is the best available evidence to me at this point in time. And if somebody comes up with something in the future that's more rigorous in some way, that says, well, actually it's fine to use clarithromycin in these patients. I'll say, well, I prescribed a lot of azithromycin for a lot of years, and maybe I didn't need to do that. But
what if, what we don't know here is, what if there's a difference in clinical outcome in terms of disease susceptibility? So that in fact, all these patients on azithromycin actually had a 1.2 or 3.4 increase in mortality.
But you're right, we don't
know that.
Right?
So
if we knew that, then that would be another piece of information
but I think
to
there's
bring
risk in just automatically assuming because you have this, that, oh yeah, you can do it. It's not, yes, it's well designed, it's an interesting look at a database, but it excluded a lot of other things that would be important.
With a pretty big effect, effect size as well. Like we're talking 4 and 6 for their odds ratios. Like that's pretty good.
They are. I'm not disagreeing with that. I'm just saying, but we don't know if any of these patients, other than their hypertension, came to any of the patients who didn't get hypertension had other harm, right?
Right.
If you're in the azithromycin class, whether or not your morbidity was up or your hospitalization was up related to whatever you were treating.
Well,
So-
that's something you could do a randomized controlled trial about, right? If you were wondering, is azithromycin more or less effective than clarithromycin for treating community-acquired pneumonia? That's a great question for a randomized controlled trial, right? But the question about harm, does clarithromycin harm people and cause hypotension if they're taking a calcium channel blocker? You can't do a randomized controlled trial to answer that question. It's just not ethical. So, I mean, you're asking two different things, and they're both very important. So there would be no point in prescribing azithromycin if there was evidence to show me that it wasn't an effective treatment for the disease that the person had. But if the evidence that we have says, you know, macrolides generally are an effective treatment for community-acquired pneumonia, then I think I'm justified in using a macrolide to treat that disease. And then the question becomes, well, in this particular patient, is there any reason why I would choose one over the other? And I think there's a reason.
But, I mean, in my mind, the big question about macrolides has always been whether azithromycin causes more in a population resistance. And there's good enough data when you look, for example, the last place I was in Kingston where they actually were collecting data, it was obvious that azithromycin resistance was growing. And that didn't seem to be, for whatever reason, like completely across the classes. It seemed to be selective for the azithromycin. Is that because so many people, like family doctors, are prescribing the Z-Pak or whatever it is? Or is that for other reasons? But I mean, when you look at it in terms of the pharmacokinetics, which again is sort of laboratory stuff, it makes sense. That stuff, it's actually a 10-day course that you take in 5 days that then sits under the kill zone, under the MIC kill zone for, 3, 4, 5 more days after the effect is done. So, you know, and I'm not sure how exactly you get that data because that's not a randomized controlled trial. That, unless I guess you randomize cities and sort of do it over decades, but.
I think, again, just not to belabor the point, in the subgroup of people we're talking about, you might have an argument that you might say, well, you know, even if there is a slight increase in terms of resistance for this particular patient who also takes a calcium channel blocker, I want to use the azithromycin. And then if you want to carry your argument through, you might say, well, for my other patients who are on a calcium channel blocker, maybe I will choose a different macrolide, or maybe I won't, depending on what I think about resistance. But that's my take. I mean, the question I think was asked, you know, did this change anybody's practice? Change my practice. So that's my answer to that
It'll
question.
make me think about my practice.
And Marilyn, does it change your practice so that you don't prescribe clarithromycin much at all anymore, or
Well, like
only
I
in those
said,
patients?
I didn't use tons of clarithromycin, but when I'm specifically looking at the patient who's on a calcium channel blocker, I don't use clarithromycin.
Because that's the only thing that I would do differently. I'm not convinced that azithromycin is a good drug for sick people, frankly. And although that's what we use it IV in the hospital, right? Because clarithromycin is not available IV. Yeah.
As part of a
As part of
double
a
or triple
yes,
antibiotic
right,
regimen,
along with
not
ceftriaxone
right.
or what have you. But frankly, this is very good practice, but it's what I sometimes do. When I get backed into a corner by a patient who is absolutely demanding, and it's that time of the day, and I just don't have the resistance
We've all been there, John.
to say, sorry, I'm not giving it to you, I'll write a script for azithromycin for 5 days. So I'm probably, because I don't think I suspect that, I mean, that guy doesn't need the antibiotic, I don't think. Now what I'm probably doing is inadvertently increasing resistance in the bacterial world. But when I see somebody who has pneumonia, I want to be sure I'm going to treat that, and particularly if they're older, I will treat with clarithromycin. I don't treat with 10 days.
You would still do that now, even?
No, I would,
Okay.
but not in the setting of a calcium channel blocker. I think I will probably alter my practice in that regard. And I suspect I'm
So what
going
would
to
you-
be forced into that because the pharmacist is going to say, I
You
don't want
realize there's a...
Right. And I actually haven't taken on a pharmacist over the phone when they've said there's an interaction. I've never actually said I don't care, or yes, I'm aware, but I want to prescribe this drug anyway. Because I'm not sure what happens at that point. They have a responsibility to protect their patient, just as we have a responsibility to protect our patient. So what happens? Do I
We win.
put the patient
You
on
get
the
that
line
on
and
the
say
tape.
go to a different
The
pharmacy?
classic-
No,
classic,
if you say you're aware and you're aware of this interaction and you're
But this
okay
is,
with it,
this is the
they-
best drug?
yeah, they record it,
Yeah.
that they
Yeah.
notified the doctor.
Let it be on his
let it
head.
be, yeah.
Okay.
And in reality, because we have this all the time when we use fluoroquinolones in
Yeah.
kids, right? Right, because the beagle puppies got bone dysplasia
Right.
associated with the use of it, so it's not good for beagle puppies, but I don't treat a lot of beagle puppies. But having said that, we treat kids, and there's no data in kids to support that, right? Even if you look at the LHSC printouts, right, whenever you get one of the bugs that are susceptible to fluoroquinolones only, it says not to be used in kids under 18 years of age. It's where you see the printout, so but that's all bogus.
So there's been a few times where I've actually written if there's an interaction, like for a quinolone and warfarin, and I know that it's the only drug I can use, I'll write it on the script and say aware of this. They're going to have their INR checked on this day and this day. Like I asked Sarah, how do I not get a call from one of you people? So that's one of the reasons. She's actually going to do
good to
Chiefs.
know.
She's actually going to do Chiefs rounds next week if anyone wants to show up.
Maybe. I'm going to be at Dublin.
You have to show up.
I see that.
Well, it's not every day we talk about the collaborator role in journal clubs, so well done. We don't always or ever talk about the collaborator role in journal clubs.
Okay.
So.
No, and that's an important collaboration. I mean, and you know, you have to listen to them. I mean, sometimes they do bring up things that you may not be absolutely cognizant of, and I think you always have the purview because it does fall in your head to override the pharmacist. I never knew what they did with that information. There must be a little file that pops up every time, right? Joubert said no again. Yeah. Yet again?
That's pretty common now.
Yeah, it's pretty common.
Any other
Thanks.
discussion about this article?